Well, thank you so much for that very kind introduction. I am delighted to be here with you today and spend a few moments sharing some of the work that we have done in our lab looking at variability in pain and response to rehabilitation treatments. Once again, I'm Abby Wilson Anderson. I'm an assistant professor within the Division of Physical Therapy, and I also direct the RAMP Research Lab, which is within the Institute of Exercise Physiology and Rehabilitation Science. So the mission of our lab is to really identify novel ways in which we can improve rehabilitation treatments for musculoskeletal pain. My clinical background is as a physical therapist. So I have a doctor of physical therapy from Mercer University. And upon graduating with my clinical doctorate, I practiced for many years as a physical therapist in both the outpatient orthopedic and acute care settings. So I treated a number of people with different chronic pain conditions. And what was very challenging and interesting from a research perspective was really the variability in pain. I could treat two patients that were very similar, and each would have a completely different response to rehab. And that was challenging, but also very interesting. And so I decided that I wanted to research this, and I have a Ph.D. in rehabilitation science from the University of Florida. So a large part of my research really revolves around musculoskeletal pain and understanding how physical therapists can better manage musculoskeletal pain. And so I have three primary research arms that I'm focused on. The first is in characterizing pain phenotypes in individuals with musculoskeletal pain. And we look at pain sensitivity with quantitative sensory testing. We also look at psychosocial factors because pain is a biopsychosocial experience. I also examine underlying behavioral mechanisms of rehabilitation treatments. And the goal is that by identifying these pain phenotypes, hopefully we can match phenotypes with treatments that really target those aberrant mechanisms for improved treatment effects. And then the third research arm that I have is really looking at how we can better implement this in the clinical environment. In addition to my research, I also teach quite a bit within the D.P.T program here at UCF, and I also mentor Ph.D. students in the Kinesiology program at UCF, and I love having a balance of teaching and research in my role here at UCF. So I want to begin by first just describing inter-individual variability and pain and kind of giving you some clinical and laboratory examples of what this looks like. So in the clinical environment, I think a really good example is looking at patients who have had a total knee replacement. And a large percentage of those patients have very good outcomes. And with a total knee replacement, they are removing the arthritic joint and replacing it with a new prosthetic knee. And so in essence, that peripheral pain generator has been removed and replaced. And like I mentioned, a majority of patients have a very good outcome and have a reduction in pain. However, there are a group of individuals, a percentage of these patients that still continue to experience persistent pain after the surgery. And so if you think about it, the peripheral pain generator is gone. And so there are likely some central factors that are contributing to why this person is having persistent pain. But ultimately, it's largely unknown what is causing the pain in this group of individuals. Now, in the laboratory setting, we can experimentally induce pain with different sensory stimuli, and the collection of methods is called quantitative sensory testing. So with quantitative sensory testing, we do apply different heat, pressure, and cold stimuli at different intensities for the purposes of characterizing pain sensitivity. So for example, we may apply a thermode set to a hot temperature that's typically a noxious temperature that elicits pain in a majority of people, just a mild to moderate pain intensity, and ask a group of individuals to rate their pain in response to the same noxious stimuli. And what's very valuable about this is that the pain stimulus is known. We know exactly what is causing the pain in this case. And what's very interesting is that while you may expect that a majority of people would give kind of a narrow range of pain ratings in response to the same exact stimulus, in fact, the literature has shown over and over again that you see every possible pain rating. So some people perceive this as not painful at all, while others perceive it as the worst pain imaginable. And so collectively, pain is extremely heterogeneous, and there is a huge amount of variability in pain. Now, the problem for this, when we look at it from a rehab perspective, is that heterogeneity produces relatively small effect sizes for rehab interventions. And the reason for that is that while pain is a very heterogeneous condition, we often apply rehab treatments in a very one-size-fits-all manner. And so with some of the work in my lab, we are trying to kind of utilize this heterogeneity to better inform who responds to what treatments. And so that brings me to my first area of research that I look at, which is characterizing pain phenotypes. So within this heterogeneous sample, there are homogeneous subgroups of individuals that have similar characteristics in terms of pain sensitivity and psychological factors. So in this study that we recently published, we compared individuals who have an irritable pain presentation, meaning they have high pain intensity, their pain persists for a long time once it's provoked, and it is very easily provoked in response to activity. We compared people with that presentation to those who are considered not irritable or do not have that presentation, and we compared them by pain sensitivity. And what we found is that individuals with an irritable presentation have much higher pain sensitivity when measured with quantitative sensory testing. So they have very low pain thresholds compared to people who have a not irritable presentation. Now, in addition to looking at pain sensitivity, we also want to look at pain-related psychological factors because pain is a sensory and emotional factors, and they work together to really shape the pain experience. Now, interestingly, this group of individuals who has that irritable presentation, they also had significantly higher levels of depression, higher levels of anger, and lower self-efficacy compared to those who did not have that presentation. Now, why this was significant or meaningful findings is that irritability is traditionally thought to reflect tissue damage. So people who have an irritable presentation have higher levels of tissue damage, but our data is showing that it also is reflective of psychological factors as well as differences in pain sensitivity. So the next step would be to then take these phenotypes and try to apply treatments that target these mechanisms that are contributing to this presentation. Now I want to switch gears and talk for a moment about a study in which we're doing that. And this is a funded project by that's been funded by the Florida Physical Therapy Association. And we are looking to see how biopsychosocial factors affect the response to resistance exercise. And the reason that we're interested in resistance exercise is that although it's a very common rehab intervention and it is effective for reducing pain, we largely don't understand which patients respond well to resistance exercise, and we also have very limited evidence on which doses of resistance exercise are most effective. And so our preliminary data, this is unpublished preliminary data, but our preliminary data does show that there are certain subgroups that seem to have more favorable reductions in pain in response to resistance exercise than other groups. And so the overall goal of this project is to look at how pain sensitivity changes in response to resistance exercise and which phenotypes respond most effectively to resistance exercise. And we're looking at this in individuals with knee pain. So this is a project that's ongoing, and we're in the data collection phase of this project right now. Now, the third thing I want to briefly talk about is that we do have phenotyping approaches in the laboratory, and we have very valid measures of pain sensitivity in the laboratory. But the caveat is that these are very expensive, difficult to maneuver sometimes, pieces of equipment that are not readily found in most physical therapy clinics. And so that's something else that I'm starting to explore, is looking at ways in which we can implement these procedures in the clinical environment with tools that are already present in the clinical environment. And so that's what I'm working on now, is developing bedside pain sensitivity testing procedures. We're also looking to do larger phenotyping trials, as well as a resistance training study in individuals with low back pain. So I'm very much welcome collaborations. I always enjoy working with people outside and within my own discipline. And I just want to conclude by really talking about the scope of the pain problem. So pain research and chronic pain is really a public health problem. Pain is more costly and prevalent than cancer, diabetes, and heart disease all combined. And this, combined with the ongoing opioid crisis, has really elevated pain research to be a national priority. So there are a number of federal research initiatives that are trying to tackle the problem of chronic pain and better investigate that. And so with all that being said, thank you so much for the opportunity to present here today. I also want to acknowledge my funding sources from the Florida Physical Therapy Association, as well as the Foundation for Physical Therapy Research. And this is truly a team effort, and I could not do it without my amazing students, my Ph.D. student, my D.P.T students, and all of my undergraduate research assistants. And I also want to thank my collaborators within the Institute of Exercise Physiology and Rehabilitation Science, as well as within the Disability Aging and Technology cluster. So thank you very much. And with that, I'd be happy to answer any questions.